Okay, so now we are going to go over diabetes. So in these, the objectives for this lecture is to identify the anatomy and function of the endocrine system relating to diabetes, explain the prevalence, etiology, pathophysiology, complications, clinical signs, and risk factors for type 1 and type 2 diabetes, recognize selected common medications used in the treatment and prevention of type 1 and type 2 diabetes, discuss adverse effects of the selected diabetes medications, and describe therapeutic effects of the selected diabetes medications, including mechanism of action. So this slide here is actually a little bit outdated, so I left it in there, but I probably should have taken it out. But I think I put, oh no, I'm so sorry. This is the new one that I put in. You guys have, that's what I wanted to say. I'm sorry. You guys have the one that's slightly older. I think on the PowerPoint PDF that you have, it says 29 million. But this is a more updated where it's 24.2 million Americans have diabetes. That's about 1 in every 10 people. And about 1 in 5 people don't know that they have diabetes. So diabetes in the United States is an epidemic for sure, and it seems to be just getting worse, which is really, really upsetting. I don't know why that slide is blank. I'm going to have to do something about that. Okay, so this is pretty much just the same, this is the same information as on the previous slide, but just in word form. So about almost 35 million people in the US, that's about 10% of the population have diabetes. About 27 million people are diagnosed and they know they have diabetes, but 7 million people are undiagnosed. They don't know. They're walking around more than likely with type 2 diabetes. I don't think many people are walking around with type 1 diabetes and not knowing it, because you can't really do that for very long. So probably close to 7 million people are walking around with type 2 diabetes, and the symptoms just haven't gotten bad enough for them to realize that they need to do something or get on some medication. And then we have pre-diabetes. We have 88 million people aged 18 years and older who are pre-diabetic. That is 34% of the adult population in the US. That is just huge. 65 years or older, 24 million people aged 65 years or older have prediabetes. And that is, prediabetes basically means your blood glucose isn't high enough to be considered diabetic, but it's higher than it should be, is essentially. You're too high to be considered healthy, but not high enough to be considered diabetic. So what's the cost of diabetes in the United States? Well, the medical cost is gigantic at $327 billion yearly. That is a combination of both the medical cost and lost work and wages. And then the medical cost for people with diabetes is twice as high as for people who don't have diabetes. So, you know, all the things, all the comorbidities that go along with diabetes, let alone the cost of their medication. So let's talk about what diabetes is and why people get it. So what happens when we eat food? So basically, you know, our food is our fuel, of course. We know that pretty much most things that we eat turn to fuel by our bodies breaking it down into glucose, which is basically what our body prefers to use as its main source of energy, is glucose. But the glucose that after our body breaks down our food, and there's all this glucose in the bloodstream, how do our cells utilize it? Well, our cells utilize glucose by using a hormone that's called insulin, and it's secreted by the beta cells of the islets of Langerhans, and it basically insulin acts like a key. So it falls into the receptors. We're just learning all about receptors. Everything has receptors. So the insulin falls into the receptors and it basically opens up the cell to allow the glucose to come into the cell and to be utilized by the cell. So when the levels of glucose in the blood start to rise, the pancreas is signaled to release the insulin. And when insulin is released, that's when it falls in. It goes into those receptors and then it opens up the cell so the cell can use the glucose. So there's the little animation there. And then the glucose can come out of the blood and into the cell. So normal glucose control, so in people without diabetes, glucose stays in a healthy range because the insulin does just what it needs. At the right time, insulin is released, carries glucose into the cells, keeps the amount of glucose in the bloodstream at an appropriate level, not too much, not too little. But if a patient is hypoglycemic, then they have not enough glucose in their blood, and then if they are hyperglycemic, then they have too much glucose in their blood. And then normal would be, it's like that just right amount. So this system is regulated by the body's needs, what the body needs at the different times. And your blood glucose spikes, then the insulin is released so that it can deal with that spike in blood glucose. So what's diabetes? So there's 3 possible reasons that somebody may develop diabetes. One would be they have too little insulin, or either no insulin is being made or too little, or the liver is releasing too much glucose, or a cell can't use the insulin. The insulin's being released, but the cell can't figure out, or something's dysfunctional, so the cell's not using the insulin well. So in an individual with diabetes, there's either the pancreas is either not making any insulin or it's not making enough. I didn't mention that in the beginning. So high blood glucose, hyperglycemia, in diabetes, blood glucose builds up for several possible reasons. So the glucose will build up in the blood either because, again, the liver's making too much glucose and it's just kind of can't keep up with it, or there's not enough insulin to carry the glucose out of the blood, or the cell just can't use the insulin to help get it into the cell and out of the blood. So a serious but really treatable condition is prediabetes. It usually precedes type 2 diabetes. So if it's caught, if prediabetes is diagnosed and the patient takes it seriously and wants to work on prevention and reversing it, then it's a wonderful opportunity for them to do that once they accept the fact that they have to make some kind of, usually a lifestyle change. It could have other things might be happening, but very often lifestyle changes can change things for the better. Because like we said, 88 million American adults, or 1 in 3, have prediabetes. And that is basically, as you can see here, it's their glucose level in not high enough to be considered diabetes, but in that kind of warning zone. So the 100 to 125 on a consistent level, their glucose is, that's for if they take a fasting blood glucose test. And then the glucose tolerance test is another. It's you fast and then you drink a really sugary drink and see how your body handles the glucose spike. So that's those numbers. And then this is fasting blood, so they're fasting for longer. And so it's basically still seeing how their body responds to the glucose. So people with prediabetes, they basically, or impaired glucose tolerance or impaired glucose fasting, impaired fasting glucose, if they take those tests and their numbers are higher, they are basically at a higher risk for developing type 2 diabetes. So it's very likely that they will down the road develop type 2 diabetes. So prediabetes refers to blood glucose levels that are higher than normal but not high enough to be diagnosed as diabetes, like we said. And most people with prediabetes develop type 2 diabetes within about 10 years or so. It just depends on the person and their particular circumstances. But the ADA, which is the American Dental Association, they estimate that about 41 million Americans have prediabetes, but we can see that the CDC doubles that. The CDC says 88. So recent studies indicate that treating prediabetes may prevent or delay type 2 diabetes depending on the individual, and lifestyle changes that include just monitoring their weight. Perhaps they need to lose a little bit of weight. Maybe they need to just increase their physical exercise. These things have been shown to prevent the onset of type 2 diabetes, which is huge. The anti-diabetic drugs, metformin, that we'll talk about a little bit more too, has also been shown to be beneficial in preventing type 2. So some people who are pre-diabetic their doctors might actually recommend that they start taking an anti-diabetic drug. Okay, let's see. I think that's all I wanted to say on that slide. Okay, so there's two types of diabetes. There is type 1 diabetes, which is when your pancreas makes either no insulin at all or just too little. And then there's type 2 diabetes, which is when the cell stops being able to utilize the insulin that's in the body. It stops being able to utilize it very well. And then because of this, over time, the pancreas just kind of stops making as much insulin because the body's not really utilizing it well. And so the body just kind of makes up for that and says, well, you're not using it, so I guess I won't make very much. So type 1 is an autoimmune disease, and it typically comes on really early in life and is defined by pretty much, either, like we said, a lack of insulin or too little insulin produced by the pancreas. And the patients that are type 1 diabetes, they are basically defined as insulin dependent. Like they are going to have to take insulin for the rest of their lives. And type 2, on the other hand, is when generally there's enough insulin being made, but the cells just don't utilize it quite appropriately. And with this type, the pancreas could stop making enough insulin over time, and they could end up needing to take insulin. But in the beginning, it doesn't always end up, they don't always have to take insulin in the beginning. Type 2 usually comes on later in life, but it's also seen in individuals who are overweight or who have a family history of type 2 diabetes, and they're seeing it more and more in kids. So it used to be something we thought just older people got, but we are starting to see it in kids nowadays as well. So type 1 diabetes, which was formerly known as insulin dependent, 1 in 10 people with diabetes have this type. So it's the less common type, but it's the more, in some ways, the more severe type. Most people under the age of 20 are when they're first diagnosed. So usually they used to call it, juvenile diabetes, because usually kids, it would show up younger, when you're younger. But it can come on later in life, but it's not as common. Usually it manifests itself young. And then the body is not making enough insulin. So insulin is always needed for treatment. It is an autoimmune disorder. Hyperglycemia is secondary to the insulin deficiency. So obviously you think about it in this order, the body stops making the insulin because the beta cells on the pancreas are destroyed. So now there's no insulin, and what happens? Your blood just gets more and more filled with glucose, and you become more and more hyperglycemic. So it's a secondary but very significant part of the disease. Insulin is not being produced as needed to help the glucose enter the cells because they are destroyed by the destroyed in the pancreas by the autoimmune, by the antibodies. And so at diagnosis, 80 to 90% of the beta cells have already been destroyed. So the antibodies that are destroying the beta cells basically have already made probably almost all of the pancreas's ability to make insulin, and or by the time the disease gets diagnosed, they may have a little bit of ability to make insulin, but very soon after, it pretty much is shut down, and then they have to just fully supplement their insulin. So the symptoms come on very suddenly, and people usually get very sick very fast, and so they usually figure it out pretty quickly what's going on. But weight loss, loss of energy, increased thirst, increased appetite, which is also called polyphagia, is increased appetite, increased urination or frequent urination, polyuria, and then increased thirst is also called polydipsia. So in type 2 diabetes, it's formally known, they used to call it adult onset and juvenile onset for the type 1, but those don't really line up as perfectly as they used to. So it's type 1 and type 2. So type 2 diabetes, the majority of people with diabetes have type 2. Most people are over the age of 40, but it is becoming more common in kids. And then type 2 more likely affects people who are overweight. And then there's specific ethnic groups that do tend to express it more. And then if there's a family history of type 2 diabetes, that increases your likelihood as well. So type 2 diabetes occurs mainly in adults, but this is just a slide showing that it is increasing in kids. These little green figures are children. So the number of kids with type 2 diabetes is increasing. And it's been pretty recent, like since the 90s, that it's increased so significantly. So type 2 diabetes, it affects, they talk about education being such a major component to preventing the disease, and I absolutely agree with that. But when you look at some of these populations, like American Indian, Alaskan Natives, for example, sometimes there's so much poverty in some of these populations, and education, yes, is so important, but what's education when you don't have access to healthy food, and when the food that is, for example, like on Indian reservations, the grocery stores and the food that's available on the reservation is oftentimes highly processed, unhealthy food. And if that's what they have access to, or if there's a culture of drinking a lot of soda, and not drinking water and just tons and tons of sugary drinks, and that's kind of a culture and that's just what's available. Yeah, education is hugely important, but I was, I was going to ask you guys in class, what other things do you think can affect the population's rate of diabetes? So what is type 2 diabetes? So I think we've kind of hit on this already. It's hyperglycemia. It's secondary to the insulin resistance. So again, hyperglycemia is kind of what manifests and shows up and makes you sick, but it's secondary to the initial problem, which is your cells aren't utilizing the insulin well. So insulin production is sufficient, but it's just not used correctly, and insulin resistance occurs when the cells have decreased sensitivity to the insulin. So the insulin's just not making it to the receptors. The cells, there's something not functioning correctly in the receptor area for the insulin, the hormone. So symptoms, again, we have that polydipsia, polyuria, feeling tired, blurred vision, and then infections. Patients who have diabetes are more prone to various infections.
Symptoms may be mistaken for other things as well, though, so sometimes it takes a while, especially if someone's in early stages, sometimes it takes a while to get a definitive diagnosis. So over time, high blood sugar can form diabetes. High blood sugar from diabetes can damage the walls of the blood vessels as well as nerves that control the heart and the blood vessels. Diabetics are more likely to have other conditions as well, other comorbidities that raise the risk of heart disease. So they're more likely to have high blood pressure. They're more likely to have too much of the bad cholesterol, LDL, in the bloodstream, and that can build up and damage artery walls and form those plaques that we talk about plaque buildups with being unhealthy in the heart, and over time the plaque can cause I have the hardest time saying this word, atherosclerosis. Oh my gosh, that's the word, atherosclerosis, which is hardening of the arteries, and then it can, of course, cause a blockage and cause like a heart attack or a stroke. So having too much of the bad cholesterol is not a good thing. And then they can also have high triglycerides, which is a type of fat that can be in the blood, which will also affect their cholesterol, the ratio of good and bad cholesterol. So these are kind of comorbidities to diabetics. And some of what I just mentioned are macrovascular complications. So these are like the arteries, like macrovascular, and can lead to coronary artery disease, like the buildup of the plaques that we just said, the LDL, the high levels of LDL, which is the bad cholesterol. So diabetics are at an increased risk for congestive heart disease, peripheral vascular disease, and stroke. Coronary artery disease is a major cause of death for both type 1 and type 2 diabetes. All of this also contributes to poor infection control and wound healing as well. So when we think about the damage for what we call microvascular complications with the nerves and the small blood vessel damage, that can cause numbness in the hands and feet. They may not realize that they have a sore. The sores don't heal. Nerve damage. Basically, they can have problems in all of these areas. Like I said, the numbness in the hands and feet, poor wound healing, poor circulation, causing problems in all of these areas, these peripheral areas, and then also with blood vessel damage, causing issues like blindness or kidney disease. So diabetes and periodontal disease are what we call a bidirectional. They're in a sort of a bidirectional relationship. Those who have difficulty maintaining a healthy blood glucose level, they tend to have really uncontrolled periodontal disease, and then studies have shown that people with periodontal disease tend to be more likely to develop type 2 diabetes or have a more difficult time controlling their diabetes. So that is one major thing that we have to be aware of with our patients. But also, people with diabetes have twice the risk of having periodontal disease. Not only that, but they also have to worry about things like chronic dry mouth and then chronic fungal infections, candidiasis. They have, because of this compromised immune system, and this environment in their mouth, they have a tendency to have a much higher rate of things like Candida albicans overgrowth. People with a poorly controlled diabetes, so if their A1C is like a 9 or higher, that means on a regular basis they are poorly controlled. They're far more likely to have periodontal disease, 3 times as likely. And then 1/3 of people with diabetes have severe periodontal disease, and you can see that by their pocket depths, their attachment loss. They'll have attachment loss measuring at least 5 millimeters or more. And then the role of periodontal inflammation is a major component in the pathogenesis of diabetes and its complications. So like I said in the beginning, it's that bidirectional relationship. When there's extreme infection, it's harder to control blood glucose. And when it's harder to control blood glucose, your body has a harder time controlling infection. It's just sort of a vicious cycle. So what do we talk to our patients about? Of course, we want to encourage them to try and stabilize their blood glucose, to maintain a healthy control over their blood glucose levels. And then we want to educate them about their risk for periodontal disease, how they're at so much higher of a risk for periodontal disease. So we want them to be coming in on a very regular basis, be taking measurements and checking all of their assessments to ensure that they're staying healthy. And if we see any changes, that we note it and talk to the patient. Of course, the better their oral hygiene care is, the better, the less likely that they're going to develop problems with periodontal issues, but they need to be aware of their susceptibility and how the glucose level and the oral hygiene play a role. So the good news about diabetes is they can avoid, in general, diabetes complications by maintaining a healthy blood glucose level. So if they stay more in a normal range, they won't have as many of these comorbidities and things. They have to understand their body and what they can and can't do. They need to learn these self-care skills and be informed about the importance of their diet, what foods are going to make their body react a certain way, what foods they can and can't eat, when they should be eating, when they should be taking their medication, all these things. They need support for this, support from, of course, a healthcare team, but also from their family. And then they really have to make sure they take the medication as prescribed. I can't tell you how many patients that I've had in my chair as a practicing dental hygienist who said, well, yeah, my doctor said I'm, diabetic. They just got diagnosed with diabetes and they wanted me to take this medication, but I haven't started taking it yet. And maybe just because they don't feel sick enough. And so they just aren't convinced that they need to take the medication. People with diabetes can lead a full and productive life as if they've, kind of follow these steps laid out here. So keeping the blood glucose in a target range is going to reduce their heart disease, it's going to reduce kidney disease, it's going to reduce nerve damage, eye disease. So there's a lot of motivation to reasons why they should want to keep their blood glucose in a healthy range. And then keeping their A1C at a good target. So, keeping their A1C at a 7 or below is, really important because, again, they're going to reduce the risk of heart attack, eye damage, and kidney disease. So let's talk a little bit more about management, so how they manage their management plan. I mentioned the A1C. So what is an A1C? A1C is basically a measurement of the glycated hemoglobin levels in the blood. So the glucose kind of binds with a red blood cell for the life of that cell. So they can take a test, they can take like a snapshot every 3 months, and they can kind of see what the average blood glucose level is over that time period. So a goal for a diabetic is 7% or under, and that would be considered, like sort of a well-maintained diabetic. And then you can see in our, I'm just going to do this here real quick just to see if this pops up what I want it to pop up. I don't think I can do this. Nope, it did not go to where I wanted it to go. Okay. Let me go back to the PowerPoint. I'm going to have to
it says to go to the clinic manual, but it obviously didn't take me there. It went to the Moodle course for some reason. So anyways, but if you look in our clinic manual, it's really important to memorize our protocol with diabetic patients. So here's a chart for the A1C. So you can see A1C 6. This is the estimated average glucose in milligrams per deciliter. So if somebody has an A1C of roughly 7, then they probably have an average blood glucose somewhere in the 150 range. So if we see patients that have higher than, if someone has an A1C of an 8, their blood glucose is probably going to be higher than what we can see in our clinic. So they're going to have to go and do whatever they need to do, and then if they come back, hopefully they'll come back and their blood glucose will be lower so we can treat them. That might mean that they just took their medication at the wrong time, or they ate the wrong food or something like that, or maybe they had just eaten not that long ago and they have to kind of walk around or drink some water or something, and then you can take their blood glucose again. But if they have an established A1C that is 7 or below, usually they're going to be in a fine range where we can treat them at our clinic. So good news additionally for diabetics is that physical activity does seem to do a lot of good things for patients with diabetes, helping them to lower their risk from all these other comorbidities. If they lose weight, it's going to help them lower their risk of heart disease, reduce their need for medication, perhaps, obviously not if they're in type 1 diabetes. They'll have more energy. Of course, you'll feel good when you exercise, and it improves their overall health. So that is highly recommended for patients who are diabetic. The different medications, so we finally here we'll get into the medications. Obviously insulin for type 1 diabetes. For type 2 diabetes, there's different things. There's oral medication, and then there's oral medication and insulin, or just insulin alone. So it could be a variety of things. Some of the different oral medications, the biguanides are things like, this is one of the most common ones that you'll see. Its mechanism of action is to decrease the glucose production from the liver, so it kind of decreases how much glucose is going to come out of the liver. And the most common one that you're going to see a lot on medical histories is metformin or glucophage. You'll see that quite often. And combination pills are also available using metformin with other medications. So some of those are called glucovance is metformin and glyburide. Metaglip is metformin and glipizide. Avantamend is metformin and rosiglitazone. I always like to say them like 3 times in a row, and then I'll say it differently every time. So the biguanides, the major side effect of those are nausea, diarrhea, vomiting. Sometimes patients lose weight when they take the biguanides. And then to decrease the side effects, they usually start with a low dose and kind of ramp it up, take it with food, and it kind of, patients do better. And so the side effects kind of will go away as their bodies get used to dealing with the medication. So the next grouping of oral medications for type 2 diabetes is the sulfonylureas. That's a harder one to say, sulfonylureas. And some of these you saw could have been combined with metformin down in here, these combination pills. So people can take biguanides and sulfonylureas together, and those would be, the brand names would be Amaryl or glimepiride, diabeta, Glinase, Microname, which those are the brand names for glyburide, and then there's the glucotrol XL, which is the glipizide. The generic is glipizide, and then how do we say that?
diabetes, which is the chloropropamide. So these medications work on the pancreas to produce more insulin. So they're kind of stimulating all of these sulfonylureas. They are trying to stimulate the pancreas to create more insulin. So the biguanides are trying to suppress the amount of glucose produced in the liver, and the sulfonylureas are trying to stimulate the pancreas to produce more insulin. Major side effects of the sulfonylureas is hypoglycemia, essentially. So if you have a lot of insulin and not enough glucose, you're going to be hypoglycemic. So then you're going to be that cold, sweaty, shaky, pale. You may feel, oops, sorry if that made a loud noise. Confusion, weak, hungry. It's a yucky feeling. And then we have another category are the insulin sensitizers. So these drugs improve the insulin sensitivity to those receptors. So they're going to improve the way the cell functions with the insulin. So with this group, we have the Avandia, and this also can be mixed with the metformin. We saw some of these in combination with the biguanides earlier. But the let's see, how do we pronounce this one? Rosiglitazone and the pioglitazone. Those are the insulin sensitizers. So the major side effects there are fluid retention, weight gain, headaches and muscle pain, elevated liver enzymes. So they do check the liver prior to taking these medications. Should not take if there's a history of congestive heart failure for these insulin sensitizers, and increased chance of ovulation in menopausal women, and a decreased effectiveness of birth control. So that's pretty important if a woman is still in a childbearing years. But if a woman is starting in menopause, they could actually potentially become pregnant, because it's going to increase their chance of ovulation, which is pretty interesting. Okay, so insulin, basically there's just insulin, but they have these different speeds of action. So there's rapid insulin, short-acting, intermediate, and long-acting insulin. And then you can see the corresponding names here. So a rapid insulin would be Lispro, Aspart, or Glulazine. Then there's regular insulin, which is pretty short-acting, so in its natural state, I suppose it's just short-acting. Intermediate is NPH, and then we have Detamir and insulin glargine. And of course, hypoglycemia is a major side effect. So if someone took their insulin but they didn't eat, they're going to not feel good. And that would be very dangerous. So they have to make sure that they're eating their appropriate meals when you're taking insulin. What affects blood glucose? So some things that can increase glucose in the blood is physical stress or illness, or, like, again, severe periodontal infection that can increase the glucose. Emotional stress, carbohydrates, obviously, and then some medications. And then what can decrease glucose? Medications, of course, and then exercise, because you're going to be burning up that fuel. So there, you guys will see the video that I made about how to use the glucometer, but you want to, it says to set up the date and time, but it's already, the ones in the clinic, you guys don't have to worry about that, and the coding, I think that this slide, I think, has to do with when we actually were in class together and we would go through this. But I made a video that showed you guys. I know it's not perfect, but then you'll also probably have a demonstration in clinic as well with Monica. So what can you do if diabetes or uncontrolled diabetes is suspected? Well, if you have a patient in your chair, you can check their blood glucose to see if they're at risk for diabetes or if they have diabetes. You can refer the patient to a physician, especially if you take their blood glucose and their number is really high, they should be referred to a physician. You can also refer them to diabetes educators. Encourage the patient to take care of their diabetes, especially if you have them in your chair, they're a captive audience. You can talk to them about the risk of periodontal disease and diabetes while you have them, and that might encourage them to take the action that they need to get their diabetes diagnosed and under control and medications that they need. And here are some resources for that you guys can, you have on your other slide. All right, so there we go. This is just in case we can't get through it all in class, but at least we have it recorded here.